I don't know if any of you noticed, but we just went back in time. Our timer restarted. So if we can go ahead and go to the next slide, we just have some housekeeping items for everyone to be aware of today. So we're going to go ahead and kick off this session this morning with a panel. We're excited for that panel. I'll get them up here soon, but wanted to explain how today is going to work for everyone. It's going to be a little bit different than yesterday. We're going to have a panel first. Immediately after that, we're going to break everyone up into organization type meetings. So we're going to put children's hospitals with children's hospitals, large health systems with large health systems. We're going to be talking about the needs that are unique to organizations of your size and type. This is actually feedback we got from last year's summit that we wanted to connect with people who are like us, and so we're giving an opportunity to do that this morning. So that'll be the first session. After that, we're going to have some more breakout presentations from some of our faculty members. This is when Ohio State will be here, so if you were looking for them yesterday and they weren't upstairs, it's because their plane got delayed. So they are here today, right? Are they here? I'm assuming. I actually didn't check, so maybe I should. Are they here? Okay, perfect. Yeah, hi, welcome. So we'll have that session today. I wanted to talk about the afternoon a little bit, though. So the highest rated session of our event last year was our networking event. The lowest rated section of our event last year was our virtual networking event. Some of our faculty members who were here last year know that, where we were in a room with a laptop and virtual people didn't come to the to the networking. And so I wanted to, but the feedback for the in-person was the most positive we'd gotten. It was almost a perfect score. Everyone really enjoyed it. So we wanted to make sure that we expanded that this year. We have more rooms going on at a time. We're going to have 3 hours of kind of networking time. It's going to be organized speed dating. So you're going to be, on the back of your name cards, you'll have a schedule. Follow that schedule, please. We've put a lot of effort into reaching out to you to see who you'd like to connect with, putting you in those rooms first, kind of coordinating your day so you don't have to make the we're not going to have any transition time between these. So we want to optimize as much time networking as we can. So please follow that schedule closely. Look at that. Go to those rooms. It took a lot of work to make this happen, so we want to make sure that you get as much value out of it as we can. The last thing of the afternoon, one last announcement. This is for healthcare organizations only. So if you are a vendor or a third-party service firm, we apologize, but respond to some emails during that time. This is for the healthcare organizations only. The last thing will be there's a team debrief and planning session. We understand that some people will be leaving at this time, but we wanted to, some of the feedback we got as well in previous years was the summit's great. We love the learning. We come back to our job and we just get right back to work and we don't do anything with the feedback that we learned. So we wanted to give you time to get back together with your team, put together kind of, this is what we've learned, this is what we want to take back to our organization. We want to start the beginnings of a plan of what we hope to change. So we're giving you time at this summit to do that. If you're here, please come to that. It'll be good. We'll be back in this ballroom for it. The KLAS team will be roaming around, asking you questions, seeing how we can support you during that time. Are there surveys that we can do? Are there case studies that we can send over as evidence? You know, can we put together a presentation for your executive team to help convince the value of this program? Things like that. So any questions about that? We don't need to worry about roaming mics at this point, but if you have any questions about that, I want to make sure we get them out of the way now, because today is, at least historically speaking, the most valuable day of the summit, and the opportunity to connect and to have these conversations is really, really important. So I want to make sure that everyone understands what we're trying to do today. Man, I am so great at explaining things. Okay, I will turn the time over to our panelists now. Jennifer, you are up.
All right, good morning, everyone. There's nothing to make you feel short like sitting in a chair where you can't sit all the way back or your feet don't touch the floor. But it's great to be with you today. It's been so fun to be part of the conference with all of you and so energizing. And I am really grateful to our panelists for graciously accepting our invitation to talk about patient-centered care this morning. So let me just introduce you to them briefly. We have Kirsten Davidson. She's joining us all the way from Australia, so thank you for that. She is from Royal Children's Hospital, where she is a clinical nurse consultant. Kirsten is an experienced consultant, educator, and pediatric nurse working in the EMR, Informatics and Education team at the hospital. And this team leads innovation in nursing workflows, relevance and usability of the EMR, plus the integration of technology for improvements in nurse efficiency and satisfaction. She holds a clinical nurse position working as a member of the Platypus nursing team, caring for patients and their families who require specialist care for a range of surgical specialties. So welcome, Kirsten. Next, we have Danielle Sims joining us from Ochsner Health. She joined Ochsner Health in March of 2018 as an Epic specialist, and in 2020, she actually transitioned to a new and her current role as the provider efficiency lead. In her role, Danielle and her team have created a provider-based team solely purposed around provider satisfaction with the EHR. And under her tenure, they have expanded the program from the original one to 7 functioning programs. So that's quite an accomplishment. And these programs suit all providers from the struggling to the most savvy. And then last but not least, we have Dr. Lacy Knight from Piedmont Healthcare. And Dr. Knight spent 20 years in the Northern Illinois and Chicago area as a Chief Medical Information Officer, Emergency Services Director, Independent Consultant, and Emergency Physician. So he's coming very experienced here. In 2015, he also earned a Master of Science degree in Medical Informatics from Northwestern University in Evanston, Illinois. He received his Bachelor of Arts and his medical degree from the University of Missouri-Kansas City School of Medicine in Kansas City, Missouri. He also has 2 certifications from Epic, including a Physician Builder and Physician Analytics, as well as the American Board of Emergency Medicine and American Board of Preventive Medicine Clinical Informatics. So please welcome me, or join me in welcoming these panel members with us today to talk about patient-centered care. We're just thrilled to have them. Thank you. So patient-centered care, I think, is a really broad topic, which is why we're addressing it today. But we have seen that when organizations enable a patient-centered care approach, that patient satisfaction increases and resultant outcomes improve. So it's an important buzz that we're hearing in the industry today. And I would love to just start by having each of you tell us how your organizations are defining patient-centered care, since it is such a broad topic. Kirsten, would you mind going first on that?
Yeah, so the Royal Children's Hospital in Melbourne has a very strong history, a 150-year history of providing care for our children and families, mostly in the state of Victoria, but also the southern states of Australia, and international patients as well. So we have that strong history. As a paediatric organisation, we talk about patient-centred care in terms of family-centred care, because we can't just care for the child. It's about caring for their family. And families come in all different shapes and sizes and abilities, just like our children do. So it's really important. As our organisation, part of our vision is great care everywhere, and it really impinges, that really influences how we care for our children and families. And we know by providing family-centred care, we have a big impact on the experience of care of our families, and that's really, really important to us. It's embedded in our vision, it's embedded in our goals as well, and especially we have a goal of integrity, and it's really important. The work we do, the way we work is really important as the work we do. So that approach to care is very, very important to us, and is really embedded in our organisation.
Thank you, I love that. Danielle, how is Ochsner defining patient-centered care?
Yes, so at Ochsner, we are down in the Gulf South, and our big core value, what we believe in, we eat, breathe, and sleep it, you'll probably hear me say it 7 times, patients first, always patients first. So we believe in that strongly and heavily, and with putting our patients first, we know that empowers our patients to play an active role in their care. And that just leads to so many better, improved results, less stays, less unnecessary procedures. So putting that patient in the driver's seat and letting them play an active role in their health care, it's just, patients are satisfied.
That's great. Yeah, I love that you say, you'll probably hear me say that several times. It's front and center for both organizations. Dr. Knight, how about at Piedmont Healthcare?
So at Piedmont, it's actually pretty well spelled out for us. So we have our purpose that's described as to make a positive difference in every life we touch. And so that includes our coworkers as well as our patients. And then we have something that we use as kind of our strategic plan. We call it a plan on a page. And so it's a singular document that includes all of the different pillars, but at the center of the document is our patients. And so we have two concepts that we structure that around. The first is quality, safety, service. We define that as zero harm, and market-leading patient satisfaction score, net promoter score. And the second is what we call the Piedmont Way. The Piedmont Way has three components. One is reputation in our communities for delivering exceptional quality and care. The second is providing access. And the third part is a hassle-free process to interact with the health system.
I love that you include the hassle-free process. I think that's great. When we met as a group for the first time, Kirsten made a really great point when we were talking about how you define patient-centered care, and she said, you know, that's what physicians and nurses are in the business of doing, is this patient-centered care. And so one of the things that I think we're talking about in the industry with patient-centered care is really how we are enabling patients to be in control of their care and to use technology. So I'd love to hear from each of you again how what technology your organizations are adopting to help this outreach to patients and help them be involved. Dr. Knight, would you mind starting?
Sure.
That one?
So the last two parts I mentioned about the Piedmont Way reflect access as well as hassle-free care. So we have a team that really looks at kind of all of the parts of the patient journey and maps out the technology capabilities that would enable that. And so I'll just highlight a couple of examples. The first, I think many of you also have like an app that you use for patients to engage in the system. We're an Epic shop, so we use MyChart's kind of the portion of that for the access to the clinical record, but then we've got other parts that are labeled into that. So one part includes, you know, Physician Finder, where you can see ratings of physician by real ratings for physicians on survey ratings. You can see which providers are part of our clinically integrated network, you know, who have come together with Piedmont to make sure that they agree to the quality standards that we've set forth and help us shape those quality standards. And then within that app, we also use a wayfinding portion of that. So if you're trying to find, you know, how to get to a specific office to see someone, with beacons throughout the health system to allow patients to navigate the system there. And then the other two components I'll reference are really around the access piece. So for us, a lot of that references the ability to self-schedule and online scheduling. And we recognize that while we're an Epic shop, not every provider's practice is going to be on Epic. So we feel like if you're part of that clinically integrated network, your patients need to have access to you for online scheduling. So we use Epic for the Epic-based providers, and we use a different platform for the providers that are not on Epic that blends in with their disparate EMRs, 60, 70 different types of EMRs that use that. And then the third component I'll mention is just virtual. So that's something where our approach to it is tried to make it easy for patients to interact with the physicians, easy for physicians to support it. And we recognize that we're spread across the state, so sometimes there are geographic considerations that limit a patient's ability to access their care providers. And we see the virtual health platform as a way to meet them where they are.
Okay, thank you. And Danielle, I know Ochsner is doing a lot with enabling tools for patient-centered care. Would you talk to us about that?
Yeah. What comes to mind, because, you know, we have the app that he talks about, but I really want to, for a quick second, talk about our Optimal Hospital. That's on our inpatient setting, and it's just an initiative and approach to use the technology for patients within that setting. Big thing that we're doing there is MyChart Bedside, the iPads on the bedside. That way they can be active in their care, a patient-centric approach, basically. They're looking at their labs, they're looking at their patient education, what's scheduled at what time, what's going on while they're in the hospital, and so they have everything at their fingertips. Also, with all that patient education and everything else in there, that leaves up time for the staff to go actually do things, create tasks, and do things that they need for the patient that's already taken care of, basically, for the within the app. They don't have to do it anymore. And so we do that. I know with our Optimal Hospital, stays have went down, readmission rates have went down, and it just basically lets the patient see what's going on while they're in there. Another big thing with our app, self-scheduling, all those pieces I want to talk about is the approach to patients having to be able, one second. Outside of the Optimal Hospital, there's a different approach that we use with our continuous monitoring. And with that, they also giving clinicians back time so they can spend time with the patient. Everything goes directly into the chart from their wristlets, and that way they can just, you're not waking the patient up for those checks every 4 hours, getting vitals and pieces like that. So we do those things so that way the patient can have a better stay as well.
That's great. I love the fact that you're not waking patients up. I think a lot of patients probably appreciate that approach. And I also love that you brought in that you're already seeing some results from that in readmissions going down, which I think is fantastic.
Absolutely.
Yeah, that's great. And Kirsten, when we initially met, you also mentioned how important it is to release time to care back to the clinicians. And you're about to, I believe this October, you're about to start a program to help on that journey with Epic MyChart. Would you talk about that a little bit?
Yes, so we're about to start, we're also an Epic organisation, but we're about to start our pilot for MyChart, but we're doing something a little bit different. We're actually having our consumers and our parents as part of the design of that MyChart. So they've been involved from the start and engaged, because I'm a parent, but I'm not a parent of a patient in hospital. And really, for us, it's really about making that MyChart useful for the patient or for the parent is really, really important to us. So yes, it might save time in terms of clinical messaging potentially, but really we want to make sure it's valuable for the parent. Our length of stay is very short on our pilot ward, about 4 days. So we need to streamline the ways parent can sign up, how they can access it, and also, is it going to be really useful? Most of our parents are at the bedside with the patient at the time, so we're actually communicating directly with them. Our doctor's round every morning, so it's quite a different, it'll be interesting to see how parents find this valuable. Definitely from an education perspective, it means that they can revisit that education. If they have questions after the round, we think it'll be valuable because they'll be able to message us without necessarily buzzing us, and and seeing how those sort of benefits are going to work. For the bedside nurse, it's going to be interesting to see how they interact with this, because remember, we have primary care, so I care for 4 patients and I provide all the care for those patients. So I'm always engaging and interacting with our families. So it'll be interesting to see how this pilot goes.
Thank you. I love that I've heard from all of you saying something about patient education. I think that's such an important piece of this patient-centered care. I haven't had any serious medical issues, but I know whenever something has come up for me, sometimes I feel like the clinician says something to me and my eyes glaze over and I'm like, I can't hear anything else except what you just said to me, and I don't know what it means, and I don't know what I'm supposed to be doing. So I love that you're really focusing on that patient education aspect as well. I think that's so helpful in involving them and helping them understand what's happening and the process that they'll go through. And I really appreciate how you're in a really unique situation as well, Kirsten, because you're working with the child and also the family, with these minors. So that's admirable, everything that you're doing. That's
Yeah,
great.
it adds a degree of complexity to your
Yes.
care, but as a paediatric nurse, it's actually really rewarding to work with families, and it's the why I continue working clinically, because it's really a great part of your job. It can be definitely challenging, but it's a great part of the way we care for our families and children at the Children's. Yeah.
Yeah, that's fantastic. So switching gears, just generally for all 3 of you, I'm wondering, not specifically at your organization, or maybe you're seeing some things at your organization as well, but just generally in the industry, what do you feel like are some of the barriers left that we still have to conquer to really get to this patient-centered care model? Danielle, would you mind speaking to that first?
First thing that comes to mind is with all of the new technology and all the turnover, lack of training and inadequate training for the clinicians. I know it's really hard, especially for them practicing clinically, to go ahead and attend these trainings or attend the things that need to go on with the new apps and new iPads, and making sure that the patients can get the education that they need. So I think that's a big stickler, making sure that we can get our staff trained up with the inadequate staff that we have on all of the technology that's ongoing and coming out.
Yeah, and talking about inadequate staff, you're trying to go on this journey as we're facing these staffing shortages that are very real, and so that's tricky, I'm sure. What are some of the things that your organization does to help give time to the clinicians so that they can get that education?
Absolutely. We strongly believe in less time in the EHR, more time with the patient. So we want to always make sure that we're making our providers, our nurses, the most efficient within the EHR, so that way they can spend less time there and actually be time with the patient, make it patients first. So we have a ton of programs where we make sure that our providers sit through every year to get their training. I call it spring cleaning, making sure that they're up to date, everything's personalized, they have all the new features in the system, they have those things. We have that for all providers. We have everything from programs for our most struggling. We need some time, let's get you in the system, clean everything up so that way your work is seamlessly. And that way, once again, we're giving back time with you and your patient. Everything from our most savvy providers, where we hone them in. We talk with them. We're like, what makes sense? Let's help build this in the system together. Let's get your opinion from our actual frontline workers that are out there. So that way, once again, you're not in the computer, but you're with your patient and you're spending time there.
Great, thank you. Dr. Knight, what would you add for just barriers that you see generally in the industry?
So I think Danielle really brought up a great point about time. I think that parlays into incentives. I won't go too far down that rabbit hole, but you know, the way we pay hospitals and the way we pay doctors is a model that arguably may conflict with a completely patient-centered model as it relates to the production item of that. And I think another piece is that there probably is maybe not in a complete agreement between clinicians and patients and what they believe is patient-centered. And so at least at our organization, we have a strong collaboration between folks that work on patient experience type efforts and clinician and operational efforts, but we can probably do a better job synchronizing the plans. And just to give an example of what I'm referencing, I'm thinking about, you know, the in-basket conversations from yesterday, you know, which is something that I think patients are really excited about. A lot of patients use it. But I don't know very many physicians or practices that were prepared for it. You know, I believe it's one of those things that probably requires some rethinking what the model should be from, you know, let's say 75% brick and mortar, 25% phone call, you know, in-basket messages to something where we're recruiting patients to interact with us in a digital platform for a number of great reasons. But if the model becomes significantly digital, we have to revise kind of what the operating model needs to be. So I think that's probably a big challenge as well.
Sure. I like that you're talking about, though, that shared ownership process where you're bringing different, you know, disparate parties together to talk about how you go forward together on this journey. I think that's important. And Dr. Knight also mentioned the in-basket session from yesterday, and I did attend that session this morning that Advocate Aurora did for us. If you didn't get a chance to attend, there should be a webinar link for you to watch post-conference, and if that is something that your organization is struggling with, and I've read a lot of those comments, so I think a lot of clinicians do struggle with that, I highly encourage you to watch that session. They had some great tips and things that they're doing to help relieve that in-basket for sure. Kirsten, anything you wanted to add to the barriers?
Yeah, I think it's really important to not add an additional layer of work for nursing staff. We're already the very heavy lifters in the EMR. It's important to really think about integrating some of that technology into our workflows. We upgraded our handheld devices, so we've used a mobile app since 2016, but we upgraded our handheld devices, and it was like the nurses were so happy because they finally had a functional device with a telephone. We never had a telephone before in our old Rover devices, and we've really optimized that at the bedside documentation because we know it makes them efficient, but it also helps us to engage with our families more. If we're quicker at doing the documentation at the point of care, it releases us time to care. We also introduced a new way of handing over. Instead of having or you guys call it handoff, we call it handover at the end of our shift. So instead of doing it outside the patient room, purely as an EMR review, we now take EMR out of the equation, and we've got our handheld device anyway, so we've got our little summary, we can use the Rover application for that, but we actually take it back into the room and have our family and patient at the centre of that handover, so that we talk about the patient without technology there really, and we talk about how we've cared for them, and really importantly, we engage that family in that plan of care for the next shift, and that's had really great benefits because it saved us time. We don't take ages and ages handing over. It's our double time, so we've released time to care to do all those double time tasks that we have to do. So the parents have been very happy, engaged in that part of handover, are aware of the plan for the shift, and the nurses are very happy as well because we've released time for them.
I love that you focus on helping the clinicians be more efficient so that they can spend more time with the actual patient in patient care rather than feeling like they're distracted. I think that's so important. So as we talk about patient-centered care and just the technology that we are using to connect with patients, I know there are a lot of patients who either are not technologically savvy, like I'm thinking of my parents, and I love my parents, but sometimes it's a struggle. You know, I'll get a call from my mom and she's like, I don't know how to use this app, you know, and so I think it can be very confusing if you're not someone who is technologically savvy, or, you know, for the group of patients who maybe just don't have access to technology. So what is your advice to organizations who maybe have patient populations that fall into those two groups on how they can connect with their patients and reach out to them? Danielle, do you have any thoughts on that?
I know a big thing we do with our MyChart, our My Ochsner app, proxy access, making sure that, like, I know I'm proxy on all of my parents' things because they don't get in there, they don't check those things. So if you have someone around them that can control it or can be looking out for it, whether it's your parents or your kids, I know we really educate and make sure that we have somebody that has proxy access over those charts so that way somebody who is tech savvy can take a look at that and is also real time checking everything for the patient.
That's a great idea. Kirsten, do you have any thoughts on reaching those patients?
Yeah, and I think it's really important to think about our non-English speaking families.
Great
So,
point.
you know, our MyChart will be in English. And our education is in English, so how do we really reach those families as well? Often the child is more savvy than the parent, can be more savvy than the parent on the apps, and also often our children act as our interpreters in a way as well. So I think it's really important that you don't put all your eggs in one basket because it's not going to fit. Technology does not fit for everyone, and I know myself from my mum's perspective, sure, she can use Facebook, but asking her to use an app about her health might be a different matter. And so I think it's really important to make sure that we're really looking at our individual patients and families and making sure that we actually meet their needs, not necessarily just through an app and saying, oh, here's the app, access it.
Yeah.
We still have to deliver that in-person care as well, or education.
Yeah, great perspectives, definitely, on that. As we talked about in basket a few moments ago and releasing time to care for clinicians, I know we hear a lot about burnout in the industry. We talked about burnout yesterday in our burnout panel as well. This is an area where we have the potential to further increase that technology burden for clinicians, and maybe they might experience even more burnout. So what are some of the things that you feel like we can do as an industry to still enable this patient-centered care where patients can contact clinicians, but we're not adding to that burnout? Any thoughts on that from any of you? Dr. Knight, have you thought about that?
So what the industry, that's a tough question, Jennifer. What the industry can do, you know, I think we're at a bit of a turning point. You know, there is in the beginning, I think of some of the EHR usage, people wanted more data. Now we have too much data, so we're trying to figure out how to eliminate the data. And I think years ago there were only maybe a handful of options for a given solution, but now there are many options to decipher. So certainly I can say that I appreciate the KLAS type reports that help try to filter out, you know, where you may want to start. And I think some of the industry best practices is something that's also helpful when we can get that from case studies and collaborative members and others to help provide some guidance on how to start. So I think that that's all helpful. So I don't know that I have a better suggestion for that. I did want to make a comment on something that you said earlier about you know, supporting patients, and I think it's worth acknowledging that, you know, this isn't something that patients can do self-service. I know that self-service is a lot of what we're doing in the consumer space, but it didn't always start that way. You know, when we transitioned from in airports to using mobile apps to fly, you know, those were staffed kiosks to help people do that. In the grocery store, because this maybe isn't the best idea, there still are staffed grocery store self-checkout lanes. And I think it's only in healthcare where we kind of go in with this assumption that if we email something or if we tell you something, that you've got it locked in. And through our interactions with patients during the pandemic, rolling out virtual health, we learned a lot about the different dynamics in patients. And I personally learned a lot about the geographic differences in Georgia compared to Chicago. In Chicago, there wasn't really a question of broadband. Everybody had fast internet access. In Georgia, in some areas, when we were trying to roll out kind of our initial video interacting solution, it was failing. And we did not understand that we needed to be able to throttle the quality of the images down so that can be supported on a mobile phone. And so the solution that we ended up using was one that could throttle down predating an email video quality. I think 320p is how low it goes, and we didn't really know that was going to be a need until we found out it was a problem, because our process for and it continues this way today, for setting up patients for the virtual interaction always required a handhold. We'd have somebody reach out to the patient, say, hey, I understand you're scheduled for a video visit. This is the technology that you need. This is the software that you need. What platform are you going to be using? And we needed to have people walk the patients through those things in order for that to be successful. And I think for the foreseeable future, we are going to need to continue to support patients for their interactions with us and technology.
Yeah, I'm really grateful that you brought that up, because you're right. I think we are sometimes thinking about this in a self-service mindset, and that's not really realistic with something so complex as our health and our parents' health and our children's health. So thank you for bringing in that perspective. I think that's really, really helpful. As we think about the journey toward patient-centered care, what thoughts do you each have on how organizations can measure their progress on that journey? Kirsten, do you have any thoughts on measuring progress toward patient-centered care and what organizations can do?
Yeah, we actually don't, at the Children's, we don't actually have a formalised feedback for our parents, which I started to think about last night actually. We know when we get good feedback, because we get chocolates or cards or thank yous and those sort of things. That good feedback's easy to measure. It's that concrete, and it's the other feedback. So when there's bad feedback, obviously it goes to our patient liaison and consumer liaison, and then there's family meetings and all those sort of things. But we never really survey or touch base with our families about their experience of care. And I think our MyChart pilot might be that great opportunity, because we have the first time be able to ask a questionnaire, and we have started to build in an orientation questionnaire and started to think about those sort of things. Do I have any further questions for education? And definitely we'll need a discharge one as well. How do I prepare for going home as well? So I think we've got a lot of work to do in that space, but yeah, definitely we capture the good feedback, not a problem at all.
I love that you're thinking, though, about how to continue to get that feedback from everyone. Danielle, what are your thoughts on measuring progress toward patient-centered care?
Yeah, we definitely measure at Ochsner. They do get a survey once we finish whether it's just a blood work or an actual visit. We do that, and I know that those are surveyed. We get those results. We make our work group for just about anything to make sure that all of our things are going the way they should. But even a step further, just making sure we get real-time patient feedback. We do a lot of patient outreach. We have an entire patient experience team just to make sure that the experience that they're having, whether in our clinic, our hospitals, or just out in the community, the services, we hear from them. We set up events so that way they can come in, they can sign up for these apps or things that they may not have at their homes. We're there real time with them, making sure that even in our underserviced communities, that somebody's there to get them on board with all the things that we have, letting them know what's available, and then from their perspective, what they can do to play this big role in their care.
Thank you. Dr. Knight, what are your thoughts on that, measuring progress?
So I think longitudinally, we also kind of developing that model. I think the way that we're structured today, we have a variety of patient-family advisory councils. So that is part structured feedback and partly really creating a relationship with a leader at each of our campuses. And it extends well beyond the meeting. So if there's something that comes up and that one of the patients on the panel has an opportunity or an experience, that's shared and is escalated internally. But that also served as a venue for us to collect feedback and input on things that we know are going to impact patients. So trying to think of the timing, but with the Cures Act and change to some of the release schedule timing, that was something in advance where we knew it was going to impact patients. We knew most providers that have not done it in advance of the Cures Act were a little bit hesitant to put everything out there at one time and concerned about the impact of patients. So this was something we could take to that group and say, we kind of have to do this. What can we do to make it better for you? And that led into some conversations about what type of materials and literature we were going to send out about the patients, open to dialogue for some things, and an ability to share with the patients that many of the physicians were uncomfortable with it. So that's one venue. We do collect patient feedback through surveys. We have recognized over the last year that the tool that we were using did not provide actionable feedback quickly enough. So we might get feedback, it might be great feedback, but it might take us 6 to 8 weeks to respond to something. So we're in the process of trying to implement something that can be a little bit more actionable, where we can close the loop with patients within days. So that's one example of that. And then I think the other part of how we're thinking about is what are maybe the core competencies or capabilities that we need to have in place. So I mentioned hassle-free earlier. And so one of the things that I think almost everyone has experienced is when you interact with the health system, multiple departments in one day or multiple times over the course of a day, and you're asked to repeat your insurance information. Okay?
That's never happened to me. Just kidding.
That's amazing. Well, it's probably because you've never gone to the doctor. So things like that we have as kind of core things that we know that we want to be able to do and remove as barriers. And then we also have a desire to personalize care. And for us, that means how do we get to know preferences for patients a little bit better? How can we track those and manage those? And the place where we've implemented that first is on our call center, uses some additional software to manage some preferences for patients, so that when they have the phone call, that they're calling the patient by the preferred name, they're bringing up information that may be relevant to the patient. So this is kind of where we're starting this journey.
I really appreciate that you're talking about capturing patient preferences. I think that's something that we hadn't talked about yet, that is really important for patients to feel like they really are cared for by the organization, by the clinician that's working with them. And then I wanted to circle back on something else that you said too, where you mentioned that you were gathering this feedback, but realized that you weren't responding in as quick a time frame as you wanted to. So I think one thing that all of us need to remember is that it's okay to try something and then evaluate it and then iterate and try something different and keep changing and keep evolving. I think that's something that is going to be really important as we're moving toward this patient-centered care journey. I think we have just about 10 minutes left. I definitely want to leave time for your questions as well. So maybe just one last comment from each of you on what one piece of advice would you like to give to the group today? Danielle, would you mind starting on that one?
Yes, I'll start again with patients first, always. And I think the more proactive we are, instead of being reacting, being proactive with these programs, making sure the patients are a part of it, and being a sole part in their care, the more proactive we are, the less reactive we have to be.
Yeah, I love that you talk about that proactive approach. I think that's really important. Thank you. Kirsten, what about you? Your one piece of advice, your parting words.
Yeah, I think we really have to understand our capabilities of our families and patients. It's very stressful to have a sick child in hospital, and I think that's really part of that personalised and centred care. We have to understand their capabilities, their abilities to learn at that time or to interact at that time, and also their health literacy. And it's really important, a big focus of our hospital, to improve the health literacy of our patient populations as well, because we know that helps them to be more engaged in their care, definitely.
Great, thank you. And Dr. Knight?
So I would just say, think about the impact the indirect teams or the support teams have on the patient's journey. So from an IS perspective, everything that we do touches the patient experience, but we don't always think about that, and even interactions with service desk, equipment, setting those types of things up. And then I mentioned the in-basket has come up a number of times with that too. That is something where I think the vision to do, we always want to be patient first, but I think we also need to make sure that we understand who's going to be impacted by those decisions and consider them in the design and planning.
Thank you, thank you. Well, we definitely want to hear from you, questions that you have, and I believe we have some people joining us virtually as well. So we have 2 people with mics, and if you'll raise your hand if you have a question, one of them will run to you with the mics, and that way the people that are joining us virtually, if you're using the mic, will be able to hear your question as well.
Hi, Kay Burke. I'm the CNIO at UCSF. Firstly, thank you for this very thought-provoking dialogue. So I really appreciated the panel comments today. I guess my question is, Dr. Knight, you talked about the presence of PFACs and utilizing them in your organization. I know, Kirsten, you talked about engaging patients and families with the design of your MyChart pilot. Do any of you have like technology-specific PFACs? And if so, or if not, how would you not just include the voice of the tech enthusiasts in the patient and family community, but really make sure that you have the demographic of patients and families who have no interest in technology, and really kind of having that digital divide conversation out of the gate in the spirit of tequity, which is a new emerging term here.
I hadn't heard that, but I like it.
Not mine. I cannot take any credit for tequity.
So I can probably start with that. We don't have, it's a great question. We don't have anything that's technology structured. I think perhaps unique to Piedmont because of our, the state of Georgia is largely rural, and so a lot of the population is centered around where we happen to have care sites. So a lot of our patients are staff and our employees. And so when there are things that are implemented that impact them, we have a path to get feedback that may not be kind of the non-employee piece, but we end up hearing about things that are impactful to those groups. And we have a fair understanding of the geographic differences in those communities, because those are things that we have to support with the routine technology piece. So I would say that's probably the way that we do it, but I like where you're thinking.
Kirsten or Lacy, any thoughts?
Yeah, I think it'll be interesting for us to really start to engage with our consumers on it in a different way. Also, yeah, I'm not sure what PFAF is, but yeah,
Patient
yes.
Family Advisory Council.
Oh yes, that's okay. Yeah, so we actually are starting to look at those models, and we're actually paying consumers for their input into our, starting to think about remunerating consumers for their input into our co-designs, and also our councils and things like that. So try and really get them engaged. You do have that issue where some of our more complex patients, they may get on that consumer, have that bigger consumer voice, or our cancer patients might have that bigger consumer voice, but we need to make sure that we're incorporating our surgical short stay, so we need to be more encompassing of when we reach out to consumers for feedback, I think, and engagement.
Thank you. Danielle? Everything's been said?
Yes.
All right, great. Other questions that you have that you want to ask our panelists before we conclude today?
Yeah, hi, Greta Branford, AC Mayo, Michigan Medicine. I have a question about kind of an extension of the patient portal and what your guys' experience is with other devices and other tools. So we're starting to set up hospital care at home and connected care at home. And have you used text apps, chat bots, Bluetooth devices? Like, what is your experience with that? And if you are using that, how did you encourage engagement from both the provider side and the patient side?
That's a great question.
So Danielle's going to have a lot to say about this. so I'll mention kind of where we're starting with that. You know, conceptually, where we're starting is really some of the remote patient monitoring pieces that we think are going to contribute to improving chronic illnesses. And our method for engagement is to figure out really, frankly, how the RVU credit works for the physicians and what the impact is going to be. And this is partly to just get started, because you have to have enough patients enrolled to prove the outcome benefit. But it requires some additional responsibility for the physicians. So that's our approach to trying to get the physicians engaged. We have some cohorts that have been interested in it, and then are just developing some ability to review the metrics.
Great. Danielle?
Yeah, so with Ochsner, we have two digital medicine programs live right now, one for our type 2 diabetes and our hypertension. And basically, they get these digital monitors, whether it's a blood pressure cuff or the glucometer. The readings, they go straight into the smartphone, from there into the app. That way, there's a care team around the clock, just checking those, making sure, alerting the patient if there's anything there. We do kind of have alerts for our providers, like, hey, this patient could be a part or enrolled in this program, making sure that we keep those enrollments up. Also with our patient experience and outreach, making sure that they know that these programs exist, that they're eligible for them. We run tons of reports that we can pull the amount of patients that are eligible, making sure that we're reaching out, whether it's letters or through the physician or just through their portal, letting them know that this exists and you can get enrolled in these programs. Outside of our digital medicine, we also have like our connected moms for expectant mothers. That way they get these tools as well. Lowers the visits that they have to come in. If everything's all good, they can just have that information go through as well. But then also that with them not having to go in for most visits, we have more open capability for other patients to get in.
Thank you.
Yeah, we're just going to about to pilot a bronchiolitis trial at home through Hospital in the Home and MyChart, so that the parents will be entering symptoms or how the state that their child's in, and also having the oximeter at home as well. And also we're investigating doing sleep studies at home after we've trialed this bronchiolitis trial. So we don't use any additional apps. We're hoping MyChart will help us with that, because it'll have the clinician messaging turned on in that app. I think it's really important that we don't add, when we think about bringing in new technology, that we don't add additional layers. We're trying to maximise what we have within Epic in a way, to try and, for a clinician or a parent, but or that's already there for them. They've already signed up to the portal, so to maximise those features in those portals that we already have.
Great, thank you. Great questions. Other questions that you have that you'd like to ask the panelists?
Good morning. Joel Gordon at Mayo Clinic. The Tequity conversation should probably continue. Dr. Knight, you talked about broadband, fixed broadband access being an issue, and I think it's bigger than what we think. Anecdotally, we hear people coming that drive to a church or a restaurant in order to participate in our great tools that we have. FCC states that up to 25% of rural geographies are under the required e-commerce, and in vastly rural or tribal lands, it's up to 40%. Are your organizations doing anything beyond decreasing bandwidth consumption to address that for to seek equity, such as partnerships with others that need to do e-commerce in these rural locations, legislative activities, grant writing, and that sort of thing?
I am not aware that we are formally involved in advancing that. So I don't know.
It's a tough challenge, I think, for sure. Danielle or Kirsten, any thoughts on that?
Even in metropolitan Melbourne, we have black spots for mobile reception in some of our outer suburbs, so we know that makes that difficult for families in those areas. But definitely, as a hospital with great care everywhere, we do have to start thinking about that, how we can influence access to tech and also access to reliable tech for our families.
Definitely. Thank you. Other questions that you have? That was a great one. Definitely a conversation that needs to continue, for sure.
Thanks for the presentation, really good. Does the concept, we see a lot of difficulty or challenge overcoming culture and organizational inertia across many healthcare organizations. Does the concept of a patient-centered focus help change your culture? Does it help get through organizational barriers? Does it help get execs on board with doing things? Have you seen any of that variation either within your organizations or across organizations?
So I'll start. For us, it has not been a barrier just because of how most of our facilities are community-based. The mission's pretty strong and prevalent about making a difference in each life that we touch. I would say that the biggest barrier for us is where there's friction between what's good for the patient, what's good for the provider. And I think that we will limit our ability to make impact on patients if we don't solve to the providers. So I think that's where, at least on the IT side, that's where we're focused on trying to make improvements there, where there's synergies on the patient side.
Kristen or Danielle, thoughts on your organizations with that question?
I don't think we've seen many barriers as far as like the different cultures. We definitely, like I said, we do a lot of patient outreach. We go out a lot, making sure that the underserviced communities are, they get the care that they need. I know we've like had a bunch of pop-up community testing with COVID and everything that went on. We made sure that we were in every community possible that we can get into, so that we didn't have that stipulation or that breakdown of certain populations not getting the care that they need. It just goes back to patients first, always.
Yeah. Kirsten, any other comments from you?
Yeah, RCH we're getting out into more of the regional areas, so we're having bases in our Geelong. Our surgeons go and visit down there regularly, and so we're trying to have access that way, so that parents and families don't necessarily have to come to Melbourne to access care. And also we have a good education program where we do education outreach to educate rural services on care of children and families in those specialties, to try and help with that divide as well. I think from a hospital perspective, we are about patients and families, but definitely it always helps when you're trying to get something through to exec that you do mention the patient experience of care. And definitely from a nursing perspective, that's what we're about. And really improving those things, and yeah, definitely does help get us some things over the line when we've got our families and patients at the centre of those decisions.
Yeah, just those gentle reminders.
Yeah,
definitely. I think we have time for one or two more questions. Looks like we've got one here.
Hi, this is not a question, but hopefully a helpful response to the gentleman from Mayo. I think looking at what federally qualified health centers are doing with regards to technology is a really good model, because I work for a network of FQHCs, and we've been doing stuff like this for years, trying to figure out how to connect patients in need not only to technology, but to transportation, to housing resources, food resources. There is, I think, a company or a network called Sano Health, S-A-N-O, which will give patients cell phones specifically for healthcare reasons, and like being able to use them for virtual visits. So looking at FQHCs as a model in your community would be a really great start.
Thank you so much for that comment. That's really helpful information, and some great tips you have too. Thank you. Maybe one last question. Anyone's got a question?
So this is less of a question, more of a challenge. We're all here because the Arch Collaborative has been so successful in getting the voice of the end user. Started with providers, added nurses, added allied health. My question is, when are we going to start surveying the patients as end users for these portals?
That's a great question. Yeah. I don't think I have a great answer for that myself, but does one of you have thoughts on that?
We'd be definitely happy to be the first pilot site for that. Yeah, I was thinking that, yeah, definitely we need a consumer class survey. Definitely, I think, when you think about the elements that we're asking our end users about rating us in a way and giving us feedback, they actually definitely apply to consumers as well, and our families. And so I think, yeah, definitely put us down as number one on the list. We're happy to talk about it. Yeah.
Yeah.
Taylor, do you want to talk about it, or do you want me to? You're welcome to.
Are you going to talk about Adam Sherrington's?
Yep. So Adam, we have two people at KLAS who are really looking into this right now, Adam Sherrington and Dan Check. If you are interested in something like that, please reach out to them. We are piloting this right now with a few organizations of measuring their patient feedbacks on their technology experience specifically. So we are trying to figure out how to do this, and Adam Sherrington and Dan Check are the leaders here at KLAS trying to figure it out.
And Adam might be here this morning. He's probably cheering that question was asked, so thank you. Well, thank you everyone for being here this morning, for your great questions, and thank you to our three panelists for your thoughtful responses. we have a great lineup of sessions for you today. So starting at 9 a.m., we have our organization type breakout sessions. So you're welcome to get ready and go to those rooms. Thank you so much.